Quinolones are broad-spectrum antibacterial drugs. They work especially well against many gram-negative bacteria, and newer fluoroquinolones also cover important gram-positive and respiratory pathogens. First-generation quinolones include nalidixic acid. Their spectrum is mainly gram-negative, and their clinical use is limited today, especially to uncomplicated urinary tract infections. Second-generation fluoroquinolones include ciprofloxacin, norfloxacin, and ofloxacin. They have stronger activity against a wider range of gram-negative organisms, including Pseudomonas aeruginosa. Some also have gram-positive activity. Ciprofloxacin is commonly remembered for urinary tract, gastrointestinal, and selected respiratory infections. Third-generation fluoroquinolones include levofloxacin and sparfloxacin. Compared with the earlier drugs, they have better gram-positive coverage, especially against Streptococcus pneumoniae, while still retaining useful gram-negative activity. Fourth-generation fluoroquinolones include moxifloxacin and gemifloxacin. They cover gram-positive bacteria, gram-negative bacteria, and anaerobes. Moxifloxacin is particularly noted for respiratory tract infections, including community-acquired pneumonia. Now the mechanism of action. Fluoroquinolones target two essential bacterial enzymes, DNA gyrase, also called topoisomerase II, and topoisomerase IV. DNA gyrase normally introduces negative supercoils into bacterial DNA. This helps the DNA unwind during replication and transcription. When quinolones inhibit DNA gyrase, the DNA cannot relax and unwind properly. Replication stops, transcription is disturbed, and the bacterial cell dies. Topoisomerase IV has a different key role. After DNA replication, it helps separate the newly copied DNA strands so that cell division can proceed. When fluoroquinolones block topoisomerase IV, the replicated chromosomes cannot separate correctly, and cell division fails. The combined inhibition of DNA gyrase and topoisomerase IV explains the bactericidal action of fluoroquinolones. Their killing is concentration dependent, meaning higher effective concentrations produce stronger bacterial eradication. Important adverse effects must also be remembered. Fluoroquinolones can cause tendinitis and tendon rupture, especially involving the Achilles tendon. The risk is higher in older adults and in people taking corticosteroids. Patients should stop the medicine and contact a healthcare provider if tendon pain, swelling, or signs of rupture occur. They can prolong the QT interval. Moxifloxacin is especially associated with this effect, so caution is needed in patients with cardiac disease, existing QT prolongation, or use of other QT prolonging drugs. Central nervous system effects can include headache, dizziness, insomnia, and rarely seizures. Patients with epilepsy or other seizure risk factors need close monitoring. Gastrointestinal effects such as nausea, vomiting, and diarrhea are common. Fluoroquinolones can also disturb normal gut flora and may lead to Clostridioides difficile infection and pseudomembranous colitis. To revise quickly, remember the generations by increasing coverage. Remember the targets as DNA gyrase and topoisomerase IV. And remember the major cautions as tendon injury, QT prolongation, central nervous system effects, and gastrointestinal disturbance.